So now we're going to go on to, well, actually I'm going to finish up wrist hand potpourri part 1, and then we'll go on to wrist hand potpourri part 2. As luck would have it, they segue nicely into each other. I'm going to talk briefly on, so we're in part 1 on abstracts numbers 15 and 16, because these are kind of fun. We're going to talk a little bit about ganglion cysts. Again, now we're firmly in the potpourri part of the wrist hand lecture. So, how many of you? These are also called Bible cysts. Does everyone know why they're called Bible cysts? And what is that? Yeah. Has anyone ever done that? I did that once, actually. Not a Bible. I used the biggest book I could find, the very book that told me that this was a viable strategy. It was a Rosen book, and it was at All of You, and there was a poor Latino dude who had this, really big one. It was like that big on his extensor surface of his wrist, and I said, "Okay, buddy, here we go." And he looked at me very scared, and I looked at him very scared. I lifted up and all I succeeded in doing is hurting his wrist. It didn't break the cyst. So then I read a different book. What's that? Rosen is 5 times bigger than this Bible. It was a hardcover book. Yeah, it was only about maybe 900 pages. Yeah, I think I hit him hard enough. It was pretty hard. He looked at me like I was an insane person. And I said, failed treatment. So here's a couple of abstracts. Obviously, that's a true story, and that is not a good approach to the dealings with ganglion cysts. How many of you have aspirated these things? Okay. And how many of you have seen them and decided not to aspirate it and just referred on to hand? Yeah. Okay. It's totally reasonable to refer these patients on somewhere else, okay? But these two abstracts give a little bit of evidence that it might be completely reasonable to aspirate them too. In particular, abstract 16 is treatment of ganglia by aspiration alone. It's a study that looked at 116 patients with these Bible cysts or ganglion cysts who had simple aspiration. And it was pretty interesting, to be completely honest. 2/3 of the people, and they were followed for quite a long time, 2/3 of the people with simple aspiration had complete resolution of their ganglion cyst. No recurrence. Now, abstract 15, only 1/3 of the people had complete resolution. So, we've got some discrepancies in the numbers, but nonetheless, 1/3 or 2/3 of the people, it's a really simple procedure. For those of you who have done it, what size needle did you use? 18, why? Yeah, that stuff is goo. It's honey. It's really thick. So if you're going to do this, you could use some of the cold spray or maybe a tiny little droplet of lidocaine. Aspirate the fluid. It's really gooey, so be prepared not to go in there with some very, very small gauged needle. Take a big gauge needle, and you can aspirate this out. And these two studies, and there's a study of, the first one was 116, the next one's 113 patients, both confirm that simple aspiration will permanently resolve the situation between 1/3 and 2/3 of the time. It's not great odds, but if you're dealing with poor people who are coming here, often these ganglion cysts are not that are showing up in the emergency department are not the person who have ready access to a hand surgeon. So if they are doing that, it's a reasonable approach. I would inform them afterwards that there's a half chance that it's going to recur. If it does recur, most of the time it will continue to recur. So if this is my 5th ganglion cyst, aspirating it is probably, sort of pissing in the proverbial wind. But if it's the first time that they're asking for it, or even maybe the second, it might be worth aspirating. It's low complication rate situation. I wouldn't hesitate to do this, and we do this frequently in our emergency department. But again, remember the big syringe, because if you use a little one, you'll aspirate, nothing will come out, and you'll think, boy, that was a really dumb thing. It's solid, apparently, but it isn't. All right, that's all I want to say about ganglion cysts. All right, the next couple on this I'm going to skip. They're about de Quervain's disease. I think that's a little bit afield from emergency medicine. If ganglion cysts were somewhat afield, those are very afield. The next thing I want to talk about is in numbers 23 through the end, and it's all about digital blocks. Okay, the first one that I'll mention is number 23. It's digital nerve blocks, a cadaveric study. These people are sounding the alarm on the unseen danger of digital nerve blocks. Okay, this is a very serious situation. What they did, it's hysterical. They took some cadavers and they went and did a digital block, or where they thought that one would go for a digital block, and then they finally dissected down and they said, look, you're right on top of the nerve, in some cases so close to the nerve that you could have cut the nerve. And they say, this is very dangerous. We need to not do digital blocks because you're going to cause actual nerve trauma. Now, how many of you have done more than 500 digital blocks in your career? How many fingers have fallen off or been unable to move afterwards, right? Obviously, digital blocks are completely safe, so it's a sort of silly paper. But I thought it was a little bit interesting, and it will segue into what I'm actually going to talk about, which is, how do we anesthetize the finger? So now we've got these crazy cadaver lovers saying that that you shouldn't do digital blocks. Are there alternatives to digital blocking? I personally do not like doing digital blocks, and the reason is the same reason I don't like doing LPs. I can't figure out which patients I'm not going to be able to get them on. You do a digital block, just like an LP, 90% of the time, everything's just fine. The finger goes numb after 5 to 10 minutes, and you do your repair. And then there's that 1 in 10 guy that his finger just won't get numb. And you keep putting in, all of a sudden you've got this, the finger is this thick. You're putting about 25 cc's of lidocaine. They're starting to get palpitations from lidocaine toxicity, et cetera. And their finger is not numb. So I personally hate digital blocks. I still do them a lot. But I just hate them because of that particular effect. It's the same for me with LPs. It's a 1 in 10 or 1 in 15 of the LPs. They'll be a perfectly skinny person, and for whatever reason, I feel like I'm just doing a bone marrow biopsy. I can't figure it out. So anyway, this article asks, is there any reason to do it? I mean, this is from Adam Singer. He's a well-known skin and soft tissue infection expert out of New York, and he proposed a very simple question of, why do that when you can just do simple local anesthesia for a digital laceration, right? And what he found in this 55 patients who were randomized to either a digital block versus local anesthesia, that the anesthetic effect was that sounds odd, was quicker in the local anesthesia versus the digital block. So average time to onset was about a minute or 2 in the local person, and then about 10 minutes in the digital block, and that the effectiveness, the cosmesis, everything was exactly the same. So while I think probably most of us, do most of you, when someone has, say, a laceration here, go with a digital block, or do you usually do local anesthesia? Digital block, and I have no idea why that is. I mean, honestly, what do you? Yeah, there is this question of distortion of the wound anatomy. I mean, I guess, that's a fair statement, although in the cosmesis in this particular thing, there was no change in that. I think that's fair, particularly if it's, one of these really chewed up wounds. Now, if it's someone who sliced their finger, on the bagel knife or something like that, they're usually very clean, they're very easy to deal with, and probably a local anesthesia will get you to the end point faster. If it's someone who got their finger, smashed in a door or something and it's all splintered up into pieces, maybe that's a case for a more valid case for a digital block. This isn't saying you should do one or the other. It's simply saying that if you're having difficulties, or if you want to change and start doing local anesthesia because you have not a lot of great luck with digital blocks, that's a perfectly viable strategy. The outcomes in terms of anesthesia appear to be almost identical. Who knows what a transthecal block of the finger is? Billy? Good job. Yeah, of course, Billy. So people do. This is a really interesting block. It's a block that's very commonly used in hand surgery. I had one done in one of my multiple hand surgeries. And what they do, it's very straightforward. At the proximal volar crease, you stick a needle straight down. Okay? You hit the bone. You would draw the needle just slightly, angle it forward 45 degrees, and inject a couple cc's of bupivacaine. The idea here is that the bupivacaine gets into the flexor tendon sheath, and it just goes all over the place. And I've never seen this, but I've heard of people when there's like a digital finger amputation, and they do this type of block, you just see the fluid start coming out the tip of the finger, because it's that contiguous with the tip of the edge of the finger. And so you get really good anesthesia through this. Abstract 26 is just a thought piece saying, we should do this more in the emergency department. It's a single stick. We don't know why you don't do it in emergency department. We do it all the time in hand surgery. And some of the thinking might be that it hurts the flexor tendon or something like that. But this is a widely used technique and something that maybe you should consider. And I see people nodding that actually use this technique. In fact, if we go on to abstract 24, I think this is the proof that this works even in our setting, although it's a little bit tricky. So this is digital anesthesia, 1 injection or 2. Well, obviously if 1 works, then 2 must be great. No. So this is asking us this very simple question of, do you really need to poke on both sides to try to knock out the 4 digital nerves, or can we do a single technique, a single stick technique, akin to this transthecal block? They don't call it a transthecal block in this particular paper, but it sounds like that's what they're doing. So what they do is the same exact space. They tented the finger here at the proximal volar crease of the MCP, and then they injected 2 cc's just subcutaneously. So instead of going all the way to the bone and then withdrawing slightly, they just squirted that in there and then waited and saw what happened. And in fact, they had the exact same results. They had 67% of the people had excellent anesthesia after 5 minutes with the single technique. It was actually higher than the people with the dual technique, so it was only 65%. I think it was at 10 minutes, it was about 90 and 90, so it was about the same. This is a technique I do all the time now. This is what I do to block fingers. And then if it fails, then I revert to the digital, and then if it fails, then I make the resident do something. I say, I make the mid-level. Yes, oh, can you please? Yes, yeah, I've got it all numbed up for you. Now go sew it. Oh, really? It wasn't numb? I didn't know that. I'm so sorry. Anyway, so I think these are techniques that we should know about. I think the transthecal one, in my opinion, is probably not even necessary, but this subcutaneous thing in this area probably does the work for you. I think it's probably because the bupivacaine or lidocaine or whatever seeps into the transthecal space and gets all over the place. There's actually another abstract that suggests that when you're aiming for the transthecal space, you miss it a lot, and when you miss it a lot, it doesn't matter anyway. You have the same treatment effects. That one in particular is looking at trigger fingers, but I think the point is that this is an interesting technique that probably, I don't know how many of you have ever done this technique. What's that? But it's worth a try. Since I came across all this literature, I've been doing it, and it seems to work really, really nicely. And I don't particularly like doing digital blocks. It's all weird the way you bang up against the bone and scrape the bone and everything like that. So anyway, consider that. In your future practice, give it a whirl. And we've got nodders that are saying that this works, so that's great. The abstract 25 addresses the complicated issue of when someone actually reached into a garbage disposal and chopped up their hand really badly, or punched a plate glass window or something like that. So now instead of the single laceration, you're into this situation where you've got to do 14 lacerations. Obviously, local anesthesia is not going to be optimal in that sense. Even digital blocks, where you can block all 5 fingers, I mean, you can do that. Maybe you have some palmar things, etc. Abstract 25s is is more of a thought piece than anything else, but it is a case series of 11 people who got nerve blocks to control the pain associated with repair of multiple lacerations, and they had these nerve blocks done via ultrasonography, and it's a call to say, hey, this is a technique we should revisit. Nerve blocks for the wrist, they're all described in the textbooks, but a lot of it has to do with aiming next to the radial artery, and that makes us a little bit uneasy, etc. These people claim, and again, these are ultrasonographers. They say that people didn't necessarily get a lot of training, but it's at Highland, and I know they use their ultrasound a lot, and they're expert at it. But they're making the argument that you can do this via ultrasound safely and efficiently. It's something to consider as a modality for ultrasound. I think that ultrasound in general in the emergency department is probably here to stay, and its greatest utility is periprocedurally, so I think that this might be something to consider. I have no idea how long it really takes to learn how to do it, but consider it. It might get you out of trouble in the guy who's got a shredded up hand, and you don't want to spend all day numbing up 5 fingers in a palm. All right, so now let's move on to the second chapter, which is wrist-hand potpourri part 2. And let's go right into the question of, so we've established that we are either going to do a transthecal block, or we're going to do a digital block, or maybe a nerve block. Now the question is, Okay, the laceration's all chewed up here. You got this chewed up finger here. What do you put in the syringe? So how many of you put lidocaine with epinephrine in the syringe? We've got one brave soul. And why do the rest of you not do that? Because of the epidemic of fingers falling off in response to lidocaine with epinephrine, right? It's the same epidemic. It's the same epidemic that happens when you use a digital block generally, right? When the cadaver study shows that we're tearing up their nerve. There's dogma out there that you're not to use lidocaine with epinephrine in finger injuries. I mean, it's in all the textbooks and all that stuff. Right next to that line in the textbook where it says that, it says, there's no evidence to support this practice. That in fact, in many, many abstracts, and in fact, abstracts 28, 29, 27, 28, 29, 30, and 31, and 32. So we've got like near 10 abstracts here, all say the same thing. There's no danger. These are not like 5 or 6 cases that happen. These are large series. For example, Abstract 27 is a multi-center prospective study of 3,100 consecutive cases of elective epinephrine use in fingers and hands. This is in Canada, 9 surgeons, 6 cities. It was 3,000 cases overall. Digital blocks were done by the usual methods using lidocaine with epinephrine, 1 to 100,000. And how many fingers fell off in Canada that year? None. None. No complications reported. Yes, sir.
I've been blocking fingers for 10 years now. Mm-hmm. And I've heard all this.
Mm-hmm.
But I still haven't started using it.
Yep.
I haven't found what was the benefit of using it.
That's a good question. So you use what? Bupivacaine or Marcaine, or do you use lidocaine? Well, lidocaine without epi can be problematic just because it's so short-lived. The half-life, you might, if you have more than one laceration, you might end up, the person becoming sensate again during the procedure. The bupivacaine question comes up with abstract, I'll just skip to it then, 32. And it comes to duration of action. Lidocaine without epi, I think, is too short. I think it's too quick. If you're quick and it's a simple lac, more power to you, no problem. The bupivacaine lasts too long, and in particular in this study, which is a relatively small study, but it was 12 volunteers, and they were looking lidocaine with epi versus bupivacaine, and they did a digital block on one hand with one and one hand with the other, and they found that the bupivacaine people were numb for 12 hours, okay? And the lidocaine with epi people, I believe it was more like in the neighborhood of 5 hours. 5 hours. So, 12 hours is a long time to have your finger be numb. When I go to the dentist, I don't particularly appreciate that it's numb for 2 hours after I leave. So in my view, that's maybe one of the reasons. The other reason, of course, is if you're going to do it in a local situation where you're not doing a digital block and you want to get a little bit more bloodless field, that might be a rationale for using it. I don't care. I think that ultimately they're both effective. One probably lasts a little bit longer than the other. But more importantly, we don't have to have this fear of necrosing off someone's digit as a consequence of a 1 to 100,000 preparation. There's a couple, yes, yes, in the back.
When they got a crushed fingertip with fractures, that 12 hours of bupivacaine is awful.
It's a good point.
They're not that eager to have that come back.
It's coming back though. Yes, that's a reasonable point. If they have a terribly smashed up finger, if you want 12 hours for whatever reason, then sure, bupivacaine, it'll give you that. I love when I do little dental blocks and stuff for the person in the middle of the night. Who comes in. I always use bupivacaine because I want them to get 12 hours so they can possibly see a dentist by the next morning, as opposed to sticking a little lidocaine in there. It's like they feel great in the emergency department, and then as soon as they get home, they're going to be requiring huge amounts of narcotics. So I think that point is well taken, that if you want 12, bupivacaine is perfectly reasonable. I think mostly these are just about telling us that don't be afraid of lidocaine with epi. We're very comfortable with it in other areas of the body, and there's nothing different here. Ample observational and even some controlled trials to suggest that this is not a dangerous practice. Several of the meta-analyses and systemic reviews of the literature that are included in this little bit of the chapter note that there hasn't been a case of digital necrosis in 50 years, and that when there were cases 50 years ago, it was all because they had non-commercial preparations of epinephrine. So you had a doctor out there trying to mix up They were using things like cocaine with epinephrine. It wasn't lidocaine with epinephrine. They were using cocaine and epinephrine and mixing it up themselves. So you could imagine how that might be a little bit different scenario than using a prefixed lido with 1 to 100,000 epinephrine. So knock yourselves out. I use it. That's what I do all the time. Have for quite a long time, and I've never seen a finger even go pale from it. So, which is consistent with all of these reports and several surgical stories. So let's move on. There is one particular case where you will get a white finger in contact with epinephrine. Has anyone ever had the auto injector problem? Yeah. So that happens, and you get 0.3 milligrams of lidocaine injected into your finger rather suddenly, and that will turn a finger white on occasion. And so this happened not too long ago in our emergency department when we said, you got to train the person, show them how the auto injector was, and the nurse did it to themselves. And their finger turned white, yeah, pretty white. So how do you treat it? What's that? Nitro, okay, we've got them all here. So we've got hot, nitrofentolamine, okay? I think that, there's no evidence to support the use of any of those because it's not that common of an event. So there's probably never going to be evidence that, oh yes, phentolamine saves them. I think it's perfectly reasonable to put the finger in a dependent position to try to encourage blood flow, to warm the finger to the best of your ability. The nitro, again, makes a certain amount of physiologic sense. But if the finger is really going to rot off, it's been hours or something like that, you're very, very concerned. What will reverse it, what has been demonstrated to really reverse it, is phentolamine. Both physiologically, it makes sense. It's a powerful alpha blocker. And there's some empiric studies that show it. Abstract number 33 is just a description of how to do this, the phentolamine, for someone who had an auto-injector injury with lidocaine. And they basically describe doing a digital block with phentolamine. Okay, and in this particular case, they waited 15 minutes. What happened in the particular case they're describing is the finger went from completely white to 2/3 white, and then they did another digital block just halfway up the finger this time, and then the finger completely pinked up. So this is a case report. What are you going to do with case reports? But it is a reminder that if you really have someone with a terribly white, painful finger, you're concerned about it, and you want to do something, and you think you really need to do something, as opposed to just put a warm towel on it or something like that. If you feel you need to intervene, this is probably your intervention, and that's the technique to intervene with. The next article in this sort of series on auto-injectors, there's only two, is the 6 years of, is number 34, it's 6 years of epinephrine digital injections, absence of significant local or systemic effects. So this is one of these poison control studies where they say, oh yeah, a bunch of people called us and told us that they had stabbed themselves with an epi auto injector, and we're going to tell you what happened to those people. So it's 127 accidental auto injections over a 6-year period. So it happens. This is just Texas. It's not common, but it does happen. 54% of them, so the majority, were managed at home. Right, so evidently they got injected, but it didn't get into their finger very effectively. So most of them will be just fine with nothing. Nothing ever happened. Only 13% of them actually had bothersome symptoms like a painful digit or a white finger. One of them had a really, really white finger. They were really worried about, and so that was the only one that had a really white finger, and then other ones had a varying sort of constellation of finger colors. 7 of them got phentolamine. A bunch of them got nitro patches in the ED. None of them lost their finger. So it appears to be something that can cause a lot of symptoms. You should know about the phentolamine, but it may be, it's something to know about, probably not that dangerous, and certainly treatable. All right, I'm going to skip the one about well, no, I'll do 35, the digital tourniquet, right? How safe is it, right? This is the danger of digital tourniquets. This is a kind of an interesting study that just says, when I do digital tourniquet, usually when I'm doing a finger laceration just to get a bloodless field, they just point out that maybe we should be careful about how much pressure we're putting on the digital nerve and artery when we do a tourniquet. When you use a rolled surgical glove and tie it down, you generate pressures of about 1,000 millimeters of mercury, which is a lot. Now if you leave someone like that for a long time while you're sewing that up, their finger might start twitching afterwards. They don't report clinical outcomes. In fact, this is a pressure gauge study, but it's kind of interesting. The pressures are a lot lower if you use a standard IV start pack tourniquet. The pressures are distributed more evenly. The bloodless field is about the same, and you get pressures more in the 300 range where you want them. There's just a little call to just be careful if you're doing a procedure that has a lot of things with it. Don't just do it, just tie the surgical glove as tight as you can, or do a Penrose drain with a clip. The pressures are really high. So I'll skip that quickly, and then we'll go on to a couple other topics. One is really important. It's abstracts 38, 39, 40, and 47. It's what to do with a smashed finger and a subungual hematoma. Right? How many of you remove the nail and try to repair that nail bed? Don't do that. How many of you have done that, tried to repair that nail bed? How enjoyable is it repairing a nail bed? Yeah, it's bamboo, right? I mean, I've done it a couple of times, and there's no conceivable way what I did to that nail bed in my attempt to repair it helped that person's nail bed. I mean, it just shreds to pieces. It's a big, giant mess. There's several abstracts in here talking about this, all of which suggest either better, at least even, clinical outcomes if you use a nail trephination technique, so you just drill a little hole in the nail, as opposed to removing the nail, repairing the nail bed, and then trying to stick the nail back on there and sew it back into place. They say that the outcomes are the same, long-term outcomes are all the same, even if there's fracture underneath it. And don't worry about the converting a closed distal tip fracture to an open one. We'll talk about that in just a second. So very good evidence. We're close to time, so I'm not going to go into all the details of the papers, but very good evidence that this is the way to go. And how you trephinate the nail, you can use your own thing. I use an 18-gauge needle and just gently bore it in. I did it yesterday, and there was no problem. It doesn't hurt or anything like that. And then you relieve the hematoma, and that may or may not relieve some of the discomfort associated with the fracture and the other issues that the person has. But don't go taking that nail off and trying to repair it. If it's already ripped off, that's what abstract 47 is about. If the nail is ripped off and there's a big lack and all this stuff, and you feel compelled to do something about it, they suggest that you get the same outcomes if you use Dermabond as if you use a detailed suturing technique. So I think that's something I haven't done, a nail bed repair with Dermabond, but they advocate for it, so something to consider. I mean, I really dislike trying to repair these nail bed things because of the texture of that skin, and I feel like I cause a lot of damage while I'm doing that. So I can't wait till the next one where the nail's already ripped off and there's a gaping hole there that I want to close up, because I'm using Dermabond. Yes, sir.
I had a case last week where the nail was pretty much 90%
Yep.
removed from the nail bed, but there wasn't a nail bed laceration.
Mm-hmm.
I used Dermabond to actually get
To stick it back on?
the hole, and rather than suture it in,
Yeah.
with Dermabond, that worked great.
Oh, that's a great technique. Yeah, how you get these nails back in and keep them there is like, its own little art form. Yeah, I drill little holes in it and then, put hey, I don't know. That's interesting. I might give that a whirl, because it is sort of silly to drill these holes and tie this thing back down. Nail trephination. That's how we do this now. The last, this might be, no, there's two more things. This question is, what is the case for non-operative management of fingertip amputations? So this is when you've smashed it and you've gone past the hematoma, past the fracture. Now you've actually cut it off. There's a little bit of exposed bone there. How do you manage these? These can be a complete nightmare, right, for many of us. If you don't have a hand surgeon, and this is often a child, so a pediatric hand surgeon, to deal with a wound that's exactly 4 millimeters, but there's just a little bit of bone there, what do you do in that situation? Okay, when I trained at all of you, there was no hand surgeon anywhere. We just learned to manage these ourselves. What we did is we rongered the bone down until there was just below the fleshy part, so that when you rubbed your finger over the top, you didn't feel any bone scraping you. And then we just put a dressing on it, and then we said, go follow up with a hand doctor someday if you can. That was our strategy. At LA County, they're very aggressive about that, but we have the hand surgeons right there, and they love to cut them down and make a beautiful flap and all these. There are several abstracts here. I think there's about 6 of them, 48, 49, 50, 51, 52, 53, 4, all of those suggesting that the first approach is perfectly adequate, that the outcomes are the same if you just rongeur the bone down just very slightly, not 5 millimeters, 10 millimeters, but just get it till it's below the surface and then put a nice non-stick dressing over the top. There's some debate in this literature about what kind of gauze you should use, but overall it looks like you can use just about anything, and that the long-term consequences are exactly the same. The same number of people that are hypersensitive in their finger with this technique as with the operative technique. Okay, none of these studies are randomized controlled trials. So that dampens some enthusiasm, but this is multiple hand surgery journals saying that this is completely fine practice. So if you're in that situation, what I would recommend, if it's not easy for you to get a hand surgeon to come in, is to not transfer that patient, to rongeur the bone a millimeter or two, put the dressing on, and make an outpatient recommendation to follow up with hand.
I've never done this. I've always had somebody
Yeah.
but now working in places where they won't be. What do you talking about?
Rongeur, so a rongeur just means to, so wire cutters, I think of them as giant toenail clippers. I mean, that's what they are, and you just, some of these papers use the word nibbling back the bone, so you nibble it down, you just sort of, you clip it off until you're just underneath the skin surface. So that's it. It's literally like wire clippers or toenail clipper, depending. I mean, they usually look more like wire clippers, but that's how I think of it. The last two sections I'm going to cover in one hot minute, and that is how important are antibiotics for hand laceration repairs in general, and then finally, how important is antibiotic treatment for open finger fractures, right? Open finger fracture, it's an open fracture. That person needs Ansef, Gent, and everything else, washout, all that kind of stuff. All of these articles go back to have the same conclusion, which is there is no value to prophylactic antibiotics. Some of these are controlled trials, some of them are observational studies, some of them are reviews of the literature. They all have the same conclusion that there's no evidence to support routine administration of prophylactic antibiotics to prevent hand infection. In the case of lacerations, the risk of developing an infection tends to be, just sort of summarizing the literature, around 2 to 3%. It's not mitigated by prophylactic antibiotics. In the case of fractures, the risk that's cited in these articles is more like 8 or 9%, probably because there's more devitalized tissue and such, but it's also not mitigated by prophylactic antibiotics. Now, that doesn't mean that if someone, got their hand smashed in a horse stable and there's manure and everything there, that I wouldn't potentially use it on those on a case-by-case basis, or they have diabetes or vasculopathy that makes you very concerned, but there's no evidence to support you're going to reduce the risk of hand or finger infections with prophylactic antibiotics, and it shouldn't be done routinely. I think that's all the time I have. I see Billy in the back.